Visit the YouTube channel and subscribe for more oncology videos. Pregnancy-associated breast cancer refers to breast cancer diagnosed during pregnancy or within 1 year after delivery. In present video, we are going to discuss about breast cancer diagnosed during pregnancy. Several studies have shown that breast cancer in pregnancy is more commonly associated with aggressive tumor biology such as a predominance of triple-negative breast carcinomas (TNBC). Pregnancy-associated breast cancer is independently associated with poorer prognosis, apart from aggressive biology. Other reasons are advanced stage of presentation and patients receiving suboptimal treatment due to their pregnancy. The possible delay in diagnosis is related to the fact that pregnancy increases breast density, making clinical examinations and mammography more difficult to evaluate. Imaging and pathological examination should be performed without delay in any case of breast lump in pregnancy. Diagnosis by core biopsy represents the gold standard for breast cancer in pregnancy like in non-pregnant patients. However, pathologists should be informed about the pregnancy. Imaging studies must be done without damage to fetus by ionizing radiation. Benefits of each modality versus the potential risks to the fetus should always be taken into account. For imaging breast and axilla, breast ultrasound as well as mammography with abdominal shielding can be safely performed in pregnant patients. Contrast MRI breast is avoided in pregnancy due to lack of safety profile of MRI contrast on pregnancy. For metastatic workup, ultrasound is the preferred imaging modality for staging the abdomen and pelvis, and chest X-ray with abdominal shielding can be done to stage the chest. In the cases of suspected bone or brain metastases or if the other imaging procedures were inconclusive, plain MRI contrast can be considered. Computed tomography, bone scan and positron emission tomography should be avoided during pregnancy. Presently, sentinel lymph node biopsy in patients with breast cancer in pregnancy is not recommended as blue dye used for mapping has the low but potentially harmful risk of anaphylactic reaction. In surgery, both breast-conserving surgery and mastectomy can be done with axillary dissection. Immediate breast reconstruction should be offered to all patients with the exception of those with inflammatory breast cancer, but lengthy procedures should be avoided. Genetic counseling should be offered for every young breast cancer patient, especially if there is a family history of breast carcinoma or a diagnosis of TNBC. Many pregnant patients with breast cancer may be less than 35 years of age. Radiation therapy is strictly contraindicated in pregnancy as the exposure of the fetus to radiation therapy can cause several adverse effects. In patients with pregnancy-associated breast cancer, chemotherapy is contraindicated during the first trimester of gestation as it is organogenesis phase, hence fetal abnormalities can occur, while it can be safely administered in the second and third trimesters, like in non-pregnant patients. Anthracycline and taxane-based chemotherapy regimens are standard of care for the treatment of breast cancer and should be recommended also in patients with pregnancy-associated breast cancer during the second and third trimesters. However, chemotherapy must be stopped at 34 weeks of gestational period as after this anytime delivery can occur, so delivery during neutropenic phase is to be avoided. Overall, chemotherapy in second and third trimester has a slight increased risk of obstetric complications like preterm delivery. Dose-dense chemotherapy should not be used in women with breast cancer in pregnancy as there is increased risk of neutropenia led to more requirement of GCSF support. Weekly chemotherapy regimens have a lower risk of hematological toxicity and also less requirement of GCSF and pre-medications. The calculation of the correct dose in women with breast cancer in pregnancy should follow the same standard procedures applied as in non-pregnant patients. Anti-HER2 therapy like trastuzumab is known to produce oligohydramnios because trastuzumab targets the HER2 oncogene, which is also expressed in the fetal kidneys, the organs responsible for producing the amniotic fluid, so anti-HER2 drugs are not recommended in pregnancy. In women with breast cancer in pregnancy, endocrine therapy is contraindicated during pregnancy. Craniofacial malformations and ambiguous genitalia have been described in children with in utero exposure to tamoxifen. Steroids are sometimes given to prevent nausea and vomiting during and after chemotherapy. Steroids should be avoided in first trimester, so does chemotherapy. Beyond that, dexamethasone and betamethasone cross-placenta hence not preferred. If necessary, hydrocortisone or methylprednisolone should be used as they are extensively metabolized in placenta. In pregnant women with breast cancer, limited data exist on the safety of neurokinin-1 receptor antagonists like aprepitant, hence, they should be avoided. Among 5-HT3 receptor antagonists, ondansetron can be safely administered during pregnancy. Lastly, On termination of pregnancy when breast cancer is diagnosed, termination of pregnancy may not be needed and may not adversely affect cancer outcome, except in few scenarios, like metastatic breast cancer diagnosed in first trimester and young patient with aggressive biology diagnosed in first trimester. In these cases, termination of pregnancy can be discussed with patients to allow full cytotoxic chemotherapy to be instituted. Concepts of oncology.